interest in endocrinology and diabetes, and I'm just going to have a quick run through and talk about puberty and growth. So I think from the point of view of what happens in schools, I fully appreciate the fact that there are children right from a very young age and progressing through to teenagers, and there can be a variety of different issues which may come up and be noticeable to school teachers to do with growth and potentially to do with puberty. So what I was going to touch on in my talk was a bit about the variation that happens during growth for children, talk about the phases of growth, talk about puberty, and those will be the main focuses of the talk. And then I'll also touch on obesity and being underweight, but I'm just going to talk about them quite briefly towards the end. So growth is obviously unique to childhood. So gaining height is unique to childhood. And we've got to remember that there's a big variation in what's normal. And so we've got a distribution which fits a Gaussian distribution. So there's a small number and a low percentage of the tallest and the shortest children, and similarly with weight. And then you've got a large bulk of the children who are in the middle. So by definition, we've got half of the children who are below and half of the children above the middle values. And also, just as a reminder, children have only got one chance to grow. So growth happens during childhood, and then children stop growing when their epiphyses fuse. And also, probably quite fortunately, there's only one chance for puberty. But puberty, although it may occur, well, it should occur in most children within a certain band. Sometimes it's early and sometimes it's late, and we'll come on to that. So we know that children grow at their fastest is in infancy. And in the first year of life, children are growing very quickly. And then throughout early childhood, they grow at a fairly steady rate. And certain things may affect that rate of growth. And so for an example, if a child has severe malnutrition, that may affect their growth, and other chronic conditions may affect growth. And then they will have their growth spurt.
Sorry to interrupt you, Jackie. I can't see any of your slides moving. Are you happy with that? Would you like me to screen share mine?
Sorry, no, they should have been right. Okay, can you see them moving forward now?
Unfortunately not, sorry.
Okay.
Would you like me to share my screen?
No, don't worry, let me go back to here again. Let me go. Are they moving forward now?
They are, yes.
Yes. Okay, so we've talked about the fact that there's a big distribution in the height and weight, and we've talked about the fact that we get fast growth in puberty, fast growth in infancy, and then you have a growth spurt between the ages of 12 and for girls, and boys have an average, they have their growth spurt at the age of 14, and growth stops when epiphyses fuse. So here's a chart which just gives an illustration of that. So children are growing very quick. You can see on the chart which has got the girls grow at their fastest when they're around about 12, and boys grow at their fastest when they're around about 14. And this will account for the fact that girls who are in round about year 8 will be shooting up and may often be a bit taller than some of the boys when they're around about 12 years of age. And then boys will still be growing quite steadily when they're about 12 or 13, and they tend to have their growth spurt at about 14. And the reason why boys on the whole are just genetically a bit taller, but the reason why they end up, or men end up being so much taller, is because they have more childhood growth and their growth spurt is late, or later than the girls. So we've got a wide variation of normal. Children tend to follow the same centile that they've started on once they get to be about 2 or 3, and they will tend to stick to that centile for their height. But they're much more likely to move up and across centiles and move upwards if they are going to become overweight, and then they move across the centiles for the weight rather than height. The height of their parents is relevant in their final height, and ethnicity is also relevant. So I often think that there may be certain times when people or parents become more conscious of issues with their children's height, and sometimes it's after the school plays or big events, and then sometimes it's on the sports pitches that issues with height and weight become more apparent. So just from the point of view in schools, if you've got the smallest children, they may need adaptations in school, they may be treated differently by their peers, and taller children are often feel quite self-conscious. And of course, obese may be self-conscious, but it's just worthwhile noting that children who are obese, that's often associated with tall stature. When children go into puberty, obviously these things become more noticeable. They may develop body odour, acne, secondary sexual characteristics, and they may, clearly girls start their periods. And for both sexes, but probably particularly girls, there's emotional lability. So another practical issue in school for obesity, there may be issues about children participating in certain activities. Some of them find it harder if they're heavier to participate in sports. They may get problems with their limbs and joints. But it's also worthwhile knowing if a child is severely obese, they may have obstructive sleep apnea. That may be associated with poor concentration, school performance. And later on in life, they may be at risk of type 2 diabetes, and indeed some children are at risk of type 2 diabetes and increased risk of certain types of cancers. And clearly, if you're for children who are overweight, they may have psychological issues, and also for children who are underweight. Children who are underweight, and we may have issues with hunger, obviously at school, and for children who have got suffering with eating disorders, they may have intrusive thoughts and obsessive thoughts to do with eating, and that may interfere with their school performance. Children may also be struggle to concentrate and just generally have low mood. So I'm just going to talk a little bit more about focusing on girls and some important points to do with puberty. So on average, girls start puberty when they're roughly about 10 in Europe. And the way they start puberty with is they develop breast buds, and then they develop changes in their secondary sexual characteristics. Puberty should happen in a steady sequence. So they may start to get breast development, and around about this time they start to get hair, auxiliary hair and pubic hair. And by the time they actually start their periods, they are well established in puberty and they've got developed breast tissue. So it's just to emphasize here that actually starting periods is a late part of puberty in girls. And starting the periods is not the start. When they start menarche, when menarche occurs, which is the onset of periods, that is not the start of puberty. The interval between the breast development stage to actually starting their periods is roughly about 2 to 4 years. Starting puberty under the age of 8 could be precocious puberty and could be abnormal. So if girls start to develop breast tissue under the age of 8, that could be abnormal. And starting periods under the age of 9, again, could be abnormal. So if somebody refers a child, and a GP refers a child to me and say they've started their periods at 9, that is abnormal, and I would always see those children. And if they've started to get breast development under the age of 8, that is not normal, and I would see them at the hospital. It's also unusual not to have started puberty by the age of 13 in a girl. So having no signs of any breast development by the age of 13 is unusual, but it is not unusual to have not started your periods by the age of 13. So that may well happen. Girls often start their periods when they're older than 13. Now, I'm just going to put this down as being a couple of caveats. It can be difficult to distinguish breast tissue versus adiposity. So, and we're certainly not expecting teachers to be judging whether girls in primary school have got breast tissue or not. And it's not unusual sometimes, particularly if girls look a bit chubby, for them to have the appearance of having some breast tissue. And I do notice that a lot of girls in primary school are wearing little crop tops, various different ages. But actually true breast tissue and palpable breast buds shouldn't really be happening under the age of 8. Now, some girls, and occasionally they may have a little bit of breast budding, which is just on its own, and that's called thelarchy. Okay, sometimes that doesn't go on and progress to full puberty, but again, some of them may be referred up to be assessed. And I'll also mention that we do see a group of girls and sometimes boys who experience physiological release of androgens. So they may develop some body odour and occasionally a bit of pubic and axillary hair, and that can be physiological. So again, if you happen to notice sometimes some of the girls in primary school may have got a bit of body odour, then that isn't necessarily onset of puberty. Just give you a couple of examples of the sorts of cases who may get referred. So a 7-year-old girl with some breast buds, and she seems to have been growing quite quickly. And these children can being a bit moody and what can be described as having a bit of attitude. So this young girl, when she was referred, and as I say, it's a fictional name, mum said she was behaving like a teenager. Tests carried out at the hospital confirmed early onset of puberty, and most situations this is idiopathic, and our job at the hospital is to exclude other causes. Rarely it can be associated with underlying medical conditions, but you can treat this and slow progress of puberty. And when this girl was treated, her mother said that it seemed like she'd got her little girl back. And the main thing would be is that she's much less moody and she's less likely to progress to have early onset of her periods. So another situation and another scenario would be a 9-year-old girl who's referred by her GP because she's already started her periods. Now, by the time she came and walked in to see me in the consultation room, even without actually fully assessing her, I could tell that she seemed much more mature than a normal 9-year-old, and she was tall and she looked much more as if she could have been about 12. So she started to get changes of puberty when she was 7. And because she was referred at the time when she was mature and her periods had already started, there were few options for treatment, and she was likely to be short at her final height because puberty had progressed quickly. And I just sort of mention here, just occasionally, it might be something that comes up in schools, is that occasionally I've seen this with asylum seekers, where children may be said to be younger than they actually are, and then so they might be in a certain year group in their class, whereas actually they could be older chronologically if we actually can identify what their definite ages are. Just for some other further information, about 1 in 10 girls will start their periods in year 6. So primary schools need to be prepared for that. And I know primary schools are, but just that is not that unusual. One in 10 girls will start periods in year 6. And they may have started to have some of the changes in puberty within the preceding year, 2 or 3 years. So just to touch on the fact that problems with periods are clearly common, and a lot of girls in the first 2 or 3 years of starting their periods will have irregular menstrual cycles, and some of them can be really quite prolonged. So if that does happen, and it seems like girls maybe are complaining frequently about having periods, that can happen. It can lead to school absence. If they have prolonged periods and problems, they may have anemia, and occasionally there might be an underlying blood clotting problem. So this can be quite a struggle for some girls because of pain and discomfort, and sometimes they may be helped by going on hormonal preparations. And there's also some terminology which is now used, and I think I'd have said probably previously, perhaps mainly third world issues, people talking about period poverty, where girls haven't got enough money or can't or their families are not financing, they're not able to actually afford sanitary products. So that means that they struggle to go to school. But also it's just in any schools, even in the UK, there was one study showing that on average, in this one study, girls were missing between 1 and 3 days a term because of their periods. And that's obviously that presents difficulties. So not starting your periods by the age of 14 is unusual in girls. And if they haven't started, no signs of puberty by 14 and no periods by 16 is unusual. And occasionally that can be because of a medical problem, but also because of eating disorders. Just going on to boys, and this is just a reminder that I think sometimes people think boys start going into puberty when their voice breaks and use that as a marker for whether they're in puberty or not. But actually, boys starting to go into puberty is with changes in their genitalia, and that happens at an average age of 11 and a half. And they may get gradual changes in axillary and pubic hair. It's very variable when their voice actually breaks, but sometimes that's the thing they feel most sensitive about. And they don't think that they're going into puberty, even though they are getting changes down below. And the growth spurt in boys is quite late in the process of puberty. So starting puberty under the age of 9 in a boy is unusual. And actually, it's really quite rare. And if boys do start to get pubertal changes under the age of 9, there's a much higher chance we might find an underlying problem. So we would definitely be wanting to see those boys at the hospital. But again, it's another caveat. Sometimes boys can get some of these issues with body odour and a bit of body hair with physiological androgen release. If boys haven't started puberty by the age of 14, that is unusual. Sorry, if they haven't started by 14, that is late onset of puberty, but it isn't actually that unusual. Mostly if boys are late going into puberty, it's idiopathic. So in converse to boys who, if they start late, it's idiopathic, but it causes quite a problem for them. So this might be a boy in year 10 who looks like he's in year 7. And about 2 or 3% of boys are not in puberty by the age of 14. So here's an example, and again, this is a fictional case, a boy who was referred at the age of 12. He was very good at football. He used to play for a local side. He didn't feel like playing anymore. He'd become withdrawn. When he came up to hospital, he told me he had just gone off football. But actually, it's because he was feeling very self-conscious about his size. And for boys who have late onset of puberty, we can give some treatment to boost progress through puberty, a short course of testosterone. So we exclude other causes, and we can offer treatment for it. And we still have to think about eating disorders in boys as a cause of delayed onset of puberty, as a potential problem. And then just briefly, I'll just mention about weight issues. So obesity can definitely cause problems, as you know. It's really, I would say, a public health issue. There are implications at school, but really for you to be aware of the fact that it's very rarely an underlying medical cause. So sometimes people think it's to do with, or it's likely to be due with hormones, but actually that's quite unusual. So up to 15% of children between the ages of 10 years and 17 years are obese, so a high proportion, relatively speaking. And behaviour interventions are introduced, and we've got various ones that we can be put on offer in Suffolk, and various ones have been researched. Some of them may offer some short-term benefit, but unfortunately it isn't often sustained. And these are sort of important points just to take on board, and I think carers, so parents and carers of young people, often overestimate the quantities of food that their children need at any particular age, and it can happen through primary school and into high school. It's quite interesting that a number of parents don't actually recognise that their child is overweight or obese, and the different strategies which are on offer are often trying to motivate the whole family in engaging with a new approach. But actually, to complete some of the programmes, it's quite variable. So I will refer young people to One Life Suffolk and to other services, and it's quite variable as to whether or not they'll engage with it, and certainly whether they'll complete them. We know that teenagers with obesity have a very high chance of progressing to be obese adults, and unfortunately, if you've got two obese parents, that markedly increases the probability of obesity in adulthood. Finally, just to briefly mention young people being underweight, and this is particularly in girls, but it can occur in boys, as you know, as well. There are a number of young people who have eating disorders, and some of these are referred to us at the hospital. Mainly they will go to the eating disorders team, but sometimes they're admitted onto the ward, and then sometimes we see them for other issues. So in summary, and apologies for my delayed start, I had some problems with the technology. I'm sure that's another epidemic of this age, at this time, with things going on electronically. I hope I've given you an oversight about what normal growth is, and a reminder that puberty happens in girls when they start to develop breast tissue. Puberty should progress in a steady manner, and it will be often at least 2 to 3 years in between starting to develop breast tissue and then starting periods. Girls tend to have their growth spurt fairly early on in puberty, and that's why they tend to be a bit taller than the boys, around about year 8. For girls, having no signs of puberty by the time they are 13 is unusual. For boys, they would tend to start their puberty when they're about 11 or 12, and they start with puberty with some changes in their genitalia, and then those changes gradually progress and they develop further secondary sexual characteristics, and they have their growth spurt quite late. It's quite unusual to have early onset of puberty in a boy, but we do see some boys who are concerned because they've had late onset of puberty. We see more boys with that problem. Having problems with puberty and feeling as though things are happening too early can cause issues because they're not prepared psychologically to have these changes in primary school, and certainly having them too late can affect young people as well. Can have a fair number of girls who may be having issues with their periods, which can affect attendance at school, and obviously difficulties with them and concentrating if they're concerned about managing their periods. We have got medical treatments can help with a number of these areas. And finally, I just touched briefly on obesity and children and young people who might be underweight. Thank you very much.
Many thanks, Jackie. What I failed to tell you at the beginning was that we have got a chat bar, and if anyone wanted to ask some questions, to type in their questions as we were going through your very informative talk, Jackie. I do wonder if anyone does want to ask a question, if you would be happy to take some questions from the floor, if anyone wants to ask any. Is that okay, Jackie?
Yes, absolutely fine. Yeah, that's fine.
So I'll just give a minute if anyone wants to ask a question.
Okay, if anybody has got any queries that they would like to pass on to Kate later, and I'll be more than happy to convey them to any answers to Kate. Okay, shall I?
Okay, thank you, Jackie. Yes, if you'd like to stop sharing your screen now.
Yeah.
So if anyone is wondering who Kate is, it's me, Kate Kingsford-Beer. I'm the lead teacher here at Ipswich Hospital. I work in the schoolroom and I work for the Radworld Trust. So we will just swap over now to Claire Wadden. So Claire, if you can share your screen. Welcome, Claire. I'm just going to give you a brief introduction. So this is the second part of the Medical Needs in Schools Suffolk workshop this afternoon, Diabetes in Childhood and Adolescence, the Highs and Lows. And it will be delivered by Claire Wadden, who is a lead paediatrician, diabetes specialist nurse, working as part of the MDT paediatric diabetes team at Ipswich Hospital. She's dual qualified, that's with paediatrics and adults, in nursing, and has 25 years experience in diabetes. Prior to this, Claire has an A&E background. Claire is based at the Diabetes and Endocrine Centre at Ipswich Hospital, but is frequently found on the wards, in schools and in the community. So I know that she's very well known locally. Claire, it's very good of you to join us this evening. Thank you very much for giving us your time today to talk about this very important subject. Once again, if anyone's got any questions, please type them in the bar as we go through, and Laura and I will monitor those. Over to you, Claire.
Lovely, thanks, Kate. Hopefully everyone can see my screen now. So I'm going to be talking about diabetes in childhood and adolescence, the highs and the lows. And it's going to be a whistle-stop tour of diabetes. So I'm part of a wider team that consists of consultant paediatricians, a consultant physician, some nurses, diabetes dietitians, psychologists, and many support staff. And all children and young people with type 1 diabetes are cared for within the secondary care setting once they're diagnosed. So a little bit of background. There's approximately 27,000 children and young people with diabetes under the age of 24 in England and Wales. And our team in this area supports over 200 children up to the age of 19. And we're governed in the care that we deliver by a best practice tariff. We know that the incidence of type 1 diabetes is doubling every decade, and diagnosis in the under 5s age group appears to be increasing quite rapidly. And when a child is diagnosed with type 1 diabetes, it has significant implications for the family, the child, and the school settings. So if we start off with what is diabetes, well, very simplistically, diabetes is about the level of glucose, i.e. the sugar in the blood, that's too high because the body cannot use it properly. And there are two main types, type 1 and type 2. But for the interests of speed during this presentation, I'm purely going to focus on type 1 diabetes. And there's currently no cure for diabetes. So type 1 is an autoimmune condition. It's caused by failure of the insulin-making cells in the pancreas to produce any insulin. It's not preventable, It's not linked to any food that's eaten, the weight of the child, or the lifestyle that they pursue. The onset develops rapidly, although we don't fully understand the lead up to it. So the whole process could have started many months or years before the actual signs and symptoms start to develop. And approximately 93% of children and young people with diabetes have type 1. So it's important for school staff that they're aware of the signs and symptoms at diagnosis, because often staff will pick up on these things, particularly after a period away from school, holiday periods. And if you have any concerns about a particular child, you pick up on any of these symptoms, it's important that you inform the parents as soon as possible and encourage them to attend the GP for assessment. So what you're looking for is that these children are typically very, very thirsty, and it's a really marked thirst. They're peeing lots, they're needing to go out to the toilet numerous times in the course of a lesson. They're very tired, possibly irritable, and there's a distinct weight loss that happens over the course of 2 or 3 weeks. And often the families themselves will attribute these signs and symptoms to other things. So the children are thirsty because it's hot weather. They're peeing lots because they're drinking lots. They've lost weight because they're growing, and they've got taller, so they look thinner. But when you put all of these signs and symptoms together, they are a classic diagnosis of type 1 diabetes. So if we think about what insulin does, it's essentially a hormone that regulates the body's blood glucose level. It's produced in the pancreas and released in response to a rise in blood glucose in the person without diabetes. And insulin itself acts as a key, so it allows the glucose to move from the bloodstream into the body's cells, where it's used for fuel for all of our daily activities. So in the body without diabetes, what's going on is that the carbohydrates, the starchy and the sugar products that we eat are digested and broken down in the stomach and the small intestines, and they pass into the blood as glucose. The blood glucose level will then rise, and the body is incredibly good at picking up this rise in blood glucose level and releases insulin from the pancreas. This insulin then allows the glucose to pass through the wall of the blood vessel and into the cells, where we use it for energy, for growth and for repair. So our carbohydrates come from a variety of foods. So in particular, we think about the carbohydrates being the starchy products, so the breads, the rice, the pastas, but equally there is carbohydrate in food, in fruit, your fructose, and in dairy products, your lactose. So carbohydrate will raise the blood glucose level when consumed, and the more the carbohydrate that's eaten, the more insulin is needed to keep the blood glucose levels in the target range. So thinking diagrammatically in terms of what insulin does, you can see here we've got a blood vessel and the squares are there to represent your glucose. So when we're eating our carbohydrate, that's passing into the bloodstream as glucose. Insulin is then released in the form of a key to unlock the wall of the blood vessel, and you've got the glucose passing from the blood vessel into the cells, where you end up with a happy and a healthy cell. And that gives us lots of energy. So when there's a lack of insulin, you've got the carbohydrates being absorbed in the same way, but the glucose can't get out of the bloodstream. And the body tries really hard to help itself out, and it passes some of that glucose into the urine via the kidneys, and it makes us pelots. That in its, when you get glucose in the urine, it draws water to it, and that increases the volume. So because that glucose can't get out of the bloodstream, you've then got a cell that has no energy, it's tired and it's thirsty. And in that circumstance, the body looks around for an alternative source of energy, and it burns fat. And that's where your weight loss comes from when these children are diagnosed. And the worrying part about burning fat is that it produces something called ketones. And ketones make the blood acid, and very simplistically, they will poison the body and give rise to a condition called diabetic ketoacidosis, DKA, which can be a life-threatening condition. So when we have a child diagnosed with type 1 diabetes, our management plan is that we want the child to remain happy, healthy, develop normally, and achieve their full potential, both inside and outside of school. We want them to be able to join in activities the same as their peers, and for it to be as a minimal disruption to their school day as possible. But actually, their health needs do have an impact during the school day. So what we're asking these families to do is to aim for a target blood glucose level of between 4 and 7 before meals. And after a meal, approximately 2 hours after a meal, we would want the blood glucose level to be less than 10. But that's a real challenge, particularly if you've got a child that's treated with insulin by injection. It's really, really difficult to achieve that. A term you're probably not familiar with, but it's something that we check each time the children come into clinic and meet up with us for assessment, is HbA1c. And the value we're looking for there is 48 millimoles or 6.5%. And that put together with their daily blood glucose levels gives us an indicator of how well things are being managed. And it's important to recognise that blood glucose levels that are too high, too low, or fluctuating significantly, so going up and down very, very rapidly, affect most areas of daily life. So they'll affect the cognitive ability and concentration of the child. And it's also common to hear the family say that blood glucose levels will affect their child's behaviour quite dramatically. So when you have type 1 diabetes diagnosed, treatment is to replace the insulin that's lacking. We can do that either with injections or insulin pump. Currently, in this area, we will start everyone on injections and then progress to a pump at a later stage. We're expecting the child and the family to test the blood glucose levels at least 5 times per day. Follow a healthy, balanced diet, take regular physical activity, and we want to meet up with them at least 4 times per year to monitor their progress. In terms of blood glucose testing, there's a variety of methods available now. The top 2 pictures that you see here are the most common meters and the lancing device or finger prick that we use. And this is the most accurate way of knowing how much glucose there is in the blood at any one time. Increasingly, technology is coming into our world, and the bottom 2 pictures you can see there are what's called continuous monitoring devices. One is what's called a flash monitor, and the other is a Dexcom monitor. And these are small sensors that are inserted just underneath the skin, and you can either use a handset that you can see in the pictures or a mobile phone to wave over the device or transmit the information to the device. And you can see it translates it into a blood glucose value. And these values, there's an approximately a 10-minute delay on these values, but The beauty of the devices is that they give you arrows telling you in which the direction the blood glucose is travelling. So you can quickly see if the blood glucose is dropping or rising. So in terms of testing in school time, the needs are dependent on the individual child and the age of the child, but the most common times we'd expect the children to test it before meals and snacks to confirm a high or a low blood glucose level, before or after exercise if they're feeling unwell in any way, and at times of stress, for example, exam times. The implications of testing in school staff, it's an invasive procedure. It's drawing blood, a body fluid. So there should be a school policy that covers this. For the child, what's vitally important is that they wash their hands before they do any kind of test, because we want the value to be as accurate as possible. And if they have eaten anything containing sugar prior to testing, this might contaminate and give a false result. School staff, if they're assisting, then we would expect them to wear gloves for any kind of invasive procedure, or if you're dealing with any body fluid. And schools should have the ability to dispose of the sharps safely, i.e. a sharps bin. In terms of food, it's an area that the parents are responsible for, even during school time. So nowadays we are expecting our children to carbohydrate count, so know how much carbohydrate is in the food that they eat, and adjust the insulin dose according to that amount. The parents should send that information in if it is a packed lunch, for example. But if the child is having a school lunch, if needs be, that information can be acquired from the caterers, and our team can support the school staff to make sure that it's accurate. We say for these children that no food is forbidden, but insulin needs to be given for any carbohydrates that are eaten. We don't recommend diabetic foods. They're highly priced and not necessarily particularly healthy. And children may need an additional snack before and during PE, depending on the length of the lesson. So it's important that they know the blood glucose level at the start of any activity, and anything less than 7, we would advocate they take an extra snack before they exercise. So hypoglycemia, hypo or low, is the most common complication of type 1 diabetes that you will see in school time. It equates to a blood glucose level of under 4. Most hypos are what we would consider to be mild and are able to be treated in a straightforward manner. They may be caused by a meal or snack not being completed, or missed, too much insulin being calculated or given. Exercise can lower the blood glucose level also. The weather has an impact, and it varies according to the child, but it could be very hot or very cold weather could lower the blood glucose. Illness will also make a difference to levels, and something that I hope won't be an issue for your children, alcohol also increases the risk of hypoglycemia. So what you'd be watching out for, most children will be able to recognise that they are experiencing a hypo. There's a variety of symptoms, they won't get all of them, and symptoms change over the course of time. But you could notice that the child complains they're hungry, they've got a shake, that they're complaining of a headache, that their lips and tongue tingle. They might feel sweaty, but it's a cold, clammy sort of sweaty, or a bit dizzy and fuzzy. As the blood glucose level lowers, they may become a bit confused, and it will affect their mood, and they may become aggressive or just sleepy. Occasionally, it's incredibly rare for it to happen in school time, but a child could become unconscious from a low blood glucose level. So most children will recognise it, and then it's important to treat it straight away. They need to confirm that the blood glucose level is below 4. They give a fast-acting glucose, and this should all be identified in the child's care plan. The child needs supervision at all times, and they need to wait for 15 minutes and then retest the blood glucose level to ensure that the treatment has been effective. What's really important during school time is that child should not be left unattended or be sent out of the classroom unaccompanied to seek help. And along the bottom there, you've got some typical things that we would treat a hypo with. So a carton of natural fruit juice contains a lot of sugar. You'd probably use somewhere between 3 and 5 jelly babies or one of the mini cans of Coke. So all contains sufficient sugar that's absorbed quite quickly, and we advocate to the families that they choose something that the child likes to treat the hypos with, because if their brain is being affected and they're becoming a bit confused, you want to put something into their mouth that they instantly recognise as liking. So things to remember: if a child is unable to test themselves, and you are unable to assist them in that, either you haven't been trained or you have forgotten how to do it or don't feel competent, then assume that it is a hypo and treat it. You're going to do them no harm by giving them sugar. It can be at the next time that they test, and we could give extra insulin to correct the situation. Hand washing is imperative. Never leave them unattended, as I've said before. Respond immediately to a child complaining that they feel hypo. Equally, in school time, having blood glucose testing on the child or very easily accessible is really important. So the flip side of the hypo is hyperglycemia. It's a persistently high blood glucose level above 14. It can be serious if it's ongoing and untreated. The signs of hyperglycemia take you right back to the signs at diagnosis. So peeing lots, thirsty, tired, possibly some tummy aches and headaches. In school time, high blood glucose levels are likely to impact on the child's ability to learn and to concentrate. So if you notice there's a particular pattern with a particular child, that they're unable to focus, for example, in the afternoons, it's always worth considering and having that discussion with the parent. Is it linked to the blood glucose? Sometimes it will be, sometimes not. So treatment for hyperglycemia is extra insulin, but this has got to be done safely. So it needs to be documented, so you need to be following what's written in the care plan, and you may need, again, the care plan should specify a discussion with the parent or carer by phone. You should be encouraging the child to drink as much as possible, allowed free access to the toilet, and to check the blood glucose level more frequently to make sure that it's coming under control. The child may also want to check for blood ketone levels if they bring in a meter to school, particularly if the blood glucose has been raised for a number of hours. So as I mentioned earlier, we've got different ways of giving the insulin. The most common is by a pen device that you can see here. And the only insulin that you will see during school time being given is a rapid acting insulin. In this area, we normally use an insulin called Nova. Will also be giving a longer acting insulin that just trickles into their body over a 12 to 24 hour period and keeps the cells generally healthy even when they're not eating. Increasingly, we're using insulin pumps, and you've got a couple of different types pictured here that delivers insulin continuously, either through a 6mm cannula. Some pumps are tubed and others are tube free. So when you're giving insulin in school, the ability of the child depends on their age, and you need to think about what support may be necessary for these children. If you are giving support, then in an ideal world, 2 members of staff should be present to check insulin dose and to supervise when the insulin is given. And we're aiming for insulin to be given 10 to 15 minutes before food. But that's the ideal, and I readily accept that in the school environment, it's a challenge. As I mentioned earlier, school staff can't decide on the dose of insulin. This must be given to the school in a written format, in the form of a care plan that's agreed between school and home, and our involvement is offered as well. Insulin that's in current use should be stored at room temperature, and again there's an issue there in schools about storing medicines safely. When the kids get to high school, they normally will carry around the insulins themselves and keep it safe, but that is dependent on the child. So just a little bit as we draw to a close about the psychological impact of a diagnosis of type 1. It has a huge impact on the child and the family, in particular during the first year after diagnosis. And it's difficult for not just the child that's experiencing it, but the whole family. And it's likened to a grieving process. There's an increased prevalence of psychological problems in diabetes, and that some of the issues that we pick up on are things like low self-esteem, anger, difficulties with friendships. There's an increased risk of eating disorders. There's an increased amount of family conflict and anxiety, and these are just a few. So the recommendations from our team is to ensure that each child should have an individual healthcare plan that's kept up to date, and we usually suggest at least an annual review. That school staff training should be updated as the children progress through the school, and that's usually annually. There is some very, very good online training that was created in the east of England by the network here, and adopted nationally, and I've given you the link in the PowerPoint here to follow it. It takes the form of 2 modules that take probably 10 to 15 minutes to do at most each. The first module is for all staff in schools, and it's just to raise awareness of diabetes. The second module is much more relevant for people that are assisting the children in school time. It's important if we get together and do some training around diabetes that you use these skills. Like anything, if you don't use them, then it's difficult to maintain your competence. And written records in school should be kept for all medicines that are administered, and it's useful, particularly in the younger age children, if you keep a record of blood glucose levels that are checked throughout the day. Okay, so thank you for your time. I've come to the end of the whistle stop tour. Any questions?
So there are no questions in the chat bar, Claire, but if there's anybody who would like to ask a question, now's the time.
There is a message from Kelly that's just coming through the chat bar that just says, given that high school age children largely manage their own care, what kind of training is given to high school staff, particularly in view of a large number of teachers?
It's a bit more of a challenge in high school because of the size of the schools and the number of teachers that are involved. We offer the same package of training to high schools, and to be fair, have been into most. What we hope to target is the staff that have most contact with the child, and then encourage them to cascade out that information to any other people that have contact.
Okay, are there any other questions? I think that's a really good question from Kelly, actually, and hopefully with the training that you have indicated to us, Claire, the online training, I think we could be perhaps suggesting to some of our high school colleagues that that would be a useful thing for staff to take.
Yeah, the uptake on the online training has been good, and it's been reported to be very valuable for school staff, and you can access it at any stage and it's free of charge.
Claire, thank you. That was very informative, both presentations, and I'm sure, like me, our Suffolk school colleagues have gained a greater insight into both of these medical needs or medical areas of need today. So thank you. We're very grateful to both you and Jackie for giving up your time today. So many thanks.
No problem.
A final word, if you weren't, those that have joined, if you weren't able to join us for all of the workshops today, or you would like to hear them again, please do visit our Radworld Trust website, and if you look under Outreach Services, Medical Needs in Schools, you will find a recording and also details of subsequent workshops, including next steps for you and your schools in the Medical Needs in Schools process. So please do take a look at the Radworld Trust website under Outreach Services, Medical Needs in Schools, Suffolk. So thank you again for our speakers today. Our next Medical Needs in Schools Suffolk workshop is going to be on pain management. That's delivered by our Oxford colleague. That's going to be delivered by Dr. Conrad Jacobs, who is a consultant clinical psychologist based in Oxford, and he will be presenting that workshop next Wednesday, the 18th of November at 3 o'clock, slightly earlier time next week. I appreciate that's difficult for some of our school colleagues to join, but please do note that we will be recording this as well. So many thanks to everyone, and see you next week.